Holy moly. So, good morning, everybody. Hope everybody is doing okay.
Morning, Madam Chair.
Take a seat. Happy to see you all. I'm sure you're all happy to see us. Not really certain if that's true, but hoping. All righty then. Let's see. So we're gonna get moving. First, I'm gonna call the joint public hearing, which will be followed by a committee meeting to order. And first up is Commissioner Barton Reeves. Commissioner?
Good morning. Good morning, Senators Austin, Hartley, Lesser, Gaston, Berthel, and Seminara, and Representatives Walker, Exum, Paris, Nuccio, Gilchrist, Dathan, Case, and distinguished members of the Appropriations and Human Services Committee. My name is Andrea Barton Reeves, and I am the Commissioner of the Department of Social Services. I am very pleased to be joined today by representatives of our sister agencies at the Departments of Corrections, Mental Health and Addiction Services, Children and Families, Developmental Services, and the Judicial Branch. DSS, as the single state Medicaid agency, is here before these committees of cognizance today pursuant to Section 17B of the Connecticut General Statutes, respectfully requesting your support and formal authorization to submit a justice-involved 1115 Medicaid demonstration waiver to the Centers of Medicare and Medicaid Services, formerly known as CMS. DSS has been working in collaboration with our state partners, and all of our state agencies are here before you today in the development of a waiver application to improve transition services and outcomes for youth and adults who are being released from judicial or Department of Corrections security facilities. We have complied with all the public posting and comment period requirements for demonstration waivers set forth by CMS. We've held 3 public hearings and facilitated numerous informal meetings with interested stakeholders, including the committees of cognizance for all the state agencies represented today. We did receive 38 public comments, and they were overwhelmingly in support of the demonstration waiver. The target population demonstrated under this waiver are detained youth under age 19 who are Medicaid eligible and for whom no demonstrated healthcare need is required. Additionally, adults who are Medicaid eligible and meet one of the following health needs: mental illness, substance abuse, chronic or significant clinical conditions, intellectual or developmental disability, acquired brain injury, including traumatic brain injury, HIV/AIDS, and pregnant postpartum, will be eligible to participate in this reentry initiative. Please know that we understand that this is a significant federal and state investment in a population that has committed a crime. We recognize that there are victims of those crimes, and I've asked my staff to work with Judicial Branch of Victim Services as well as CMS to determine if some portion of these reinvestment dollars of this demonstration waiver may be used to assist victims as well. Lastly, I would like to thank the state agency leadership here today and their staffs for contribution on this application and ongoing work for the implementation plan. All of these individuals had full-time jobs before we introduced this waiver opportunity. Additionally, each state agency has committed a significant amount of time and resources to plan for the implementation of this waiver. It represents a true collaboration of sister state agencies to better serve the residents of Connecticut. And with that, I am happy to be here today and to answer any questions that you may have. But I will also say this morning that I will turn over a bulk of the presentation to Alexis Muhammad and to Bill Halsey. Alexis is one of the constellation of many rising stars that we have within DSS, and she has done an exceptional job in preparing this waiver under Bill's directions. Bill is our Deputy Medicaid Director, and together they are the ones that pulled together this waiver. All of the state agencies coordinated these efforts so we could be here before you today. So I will step aside and let those who have done all the heavy lifting make the presentation, and I'll ask them to come forward now with your permission.
That would be great. Thank you. All right, just say your names and let's get the presentation going.
Alexis Mohammed.
Good morning, Bill Halsey.
Okay, so we are presenting today on justice involved waiver. The justice involved waiver is a waiver to amend the inmate exclusion. The inmate exclusion precludes individuals incarcerated from certain Medicaid services. So we are here to request respectfully authorization from committees. Okay. Today, in order to submit the justice involved waiver. We are welcomed here through our state partners, DOC, the Judicial Branch, DMIS, DCF, DDS, OPM. Next slide, please. In 2018, Congress passed the Substance Use Disorder Prevention and that promotes opioid recovery treatment for patients and Communities Act, Support Act. This required the U.S. Department of Health and Human Services to guide states on how to seek 1115 demonstration authority to waive the inmate exclusion. The first states who have submitted the applications were California and Washington, and they both received approval for their reentry demonstration. Montana recently received approval for the application as well. There's currently 20 states that have submitted applications, and Connecticut would like to be in the queue. The main goal of this waiver and the application is to make sure that we can submit to CMS, as there is a long queue of other states on the wait list. Next slide, please. The Connecticut Request Waiver Authority via an amendment to the Substance Use Disorder 1150 demonstration. The demonstration that provides Medicaid coverage up to 90 days for individuals incarcerated. This includes prisons, jails, and courthouses, as well as juvenile facilities. The coverage period, once again, will be 90 days prior to release, as well as post-release services in the initial targeted benefit package. Next slide, please. The goal of this demonstration is to increase coverage, continuity of coverage, improve access to services prior to release, improve coordination and communication between correctional systems, increase investments in healthcare-related services, improve connections between carceral settings and community services, also address the physical health, behavioral health, and health-related social needs, reduce deaths in near-term post-release, as well as reduce number of ED visits and inpatient hospitalizations. Next slide, please. The proposed services under the waiver, we have 3 core services. That's the transitional case management, pre and post-release, medication-assisted treatment, MAT for substance use disorder, and 30-day supply medications upon release. As you can see, there's other additional services that we plan to implement in a subsequent phase-in approach. A part of the waiver, we are applying to have health-related social needs as a component of our waiver, and this will include one-time transition and moving costs, such as security deposit, first month's rent, utility activation fees, as well as housing deposits to secure housing, including the application inspection fees, medically necessary air conditioners, heaters, humidifiers, as well as medically necessary home accessibility modifications. Next slide, please. The target population includes all detained youth under age 19. They do not need to demonstrate a healthcare need. Adults Medicaid eligible must have the following healthcare needs, and that is mental illness, substance use disorder, chronic condition, intellectual or developmental disability, acquired brain injury, including TBI, HIV/AIDS, pregnant and old postpartum. Services are needed. Through our work with our state partners, we've been able to gather data to show that approximately 12,000 adults are released from the correctional facilities each year. It's estimated that 85% of adults will meet the waiver's medical needs criteria. Approximately 650 adolescents are released from juvenile community residential centers per year. Through the Connecticut Sentencing Commission data report, it was found out that 95.5% of incarcerated population had at least one of the following, and that's mental health disorder, a mental health disorder that required treatment, a history of substance use disorder, and a substance use disorder problem that also required treatment. And about a quarter had both substance use disorder that required treatment as well as mental health disorder that required treatment. Next slide, please. Like stated, we are in the waiver application phase. So this is the first phase of the whole demonstration, and we were really eager to submit the application. So through our work with our state partners weekly, we go through what will look like in terms of implementing the demonstration. So that's called the implementation phase. And so we meet on a weekly quarter or weekly each week to decide how it will look like for the population inside the walls. CMS allows at least 90 days to review the waiver application. But as we know, there's other states in the queue, which may take longer for CMS to review, as well as implementation plans. CMS has flexibilities around submitting the implementation plan and when they'll be able to review that plan as well. The state will continue to seek stakeholder input after the submission of the state's application to CMS. Next slide, please. Federal budget neutrality. It's a funky thing called waiver math, where we are looking at hypothetical costs of the waiver. So we go through this exercise with our consultants. So under the demonstration, we have to treat costs for residents of correctional facility as if those costs were allowable under Medicaid, called hypothetical costs. The state is not liable for caseload growth for JI services and is held to an aggregate cap for administration and HRSN. Next slide, please. So in a simple example here, we have assumed the state is currently spending $10 million on transition care management services for the JI population through state-only funding. Under the waiver, those transition care management services become reimbursable under Medicaid, and thus the federal share of those costs is about $9 million, assuming there's a 9% match. For budget neutrality purposes, CMS allows the state to include $10 million as a hypothetical cost, as if we had the waiver, and thus for the purposes of budget neutrality, the $9 million in federal costs is under the $10 million threshold, meaning budget neutral. Thank you. The written comment period was from January 9th to February 8th. We held 3 public hearings between January 12th and February 6th. We received 38 comments from 10 separate parties between the 3 public hearings. All written comments and responses are posted to our Justice Involved waiver page. And here's a simple timeline. We published our public notice on January 9th. We started formal public hearings from January 8th ongoing. The first public hearing, January 12th. We had January 25th, DSS held public hearing. February 6th, our 3rd public hearing. The public comment period ended on February 8th. And we're here today for the formal legislative hearing. Once again, our dedicated webpage has the full public notice as well as our draft application for the waiver, our written comments and responses to the waiver as well. Thank you.
Mr. Halsey, do you have anything else to add?
No, just to also thank the state agency partners for collaborating on this initiative, and we're happy to answer any questions you have.
I'm sure there'll be a number of questions, and I'm going to start out with a couple of questions. You talked about the $10 million for budget neutrality that they're allowing you to claim. And when we did the substance use disorder and another waiver that we most recently did, we added in the dollars into the budget. We rebased and added in the dollars into the budget. Do you know if there's a dollar amount that should be in the budget today for fiscal 25? Which would start on July 1. I imagine you're not going to get everything up and running by June 30th. So let's talk about fiscal 25. Do you have a dollar amount that you think that we should be having in the budget relative to cost?
Yeah, I'll defer to Bill. Thank you.
So Senator Austin, we are working on the budget on a weekly basis, as Alexis would say, and we're going to develop what we're calling kind of a master worksheet that will identify all the potential revenue, first costs by each state agency, and then the potential revenue that the waiver will bring in. We don't have that done. This is simply a request to submit the waiver application to CMS as we build out the implementation plan. The implementation plan will have the true budget impact, state budget, federal revenue, kind of total picture of dollars that we'd be happy to give to you.
I'd be, because I think that we're gonna have to add the dollars in for fiscal 25. I'm assuming, or I'm hoping, praying that we're gonna get some of these dollars in before the end of fiscal 25. You know, you said 90 days, it's in a queue, even if it's 6 months. So if it's 6 months from today, we get it back in sometime in fall. Do you then have to set the program up? Is that what would happen then?
Yeah, I think your 6 month is very optimistic. I think it is going to take considerably longer for CMS to approve the waiver demonstration. We've been hearing that there's somewhere in the neighborhood of 18 to 20 just justice involved waivers, but the same CMS team reviewing all waivers has about 70 to review, unrelated to justice involved, just
Right.
total waivers. So we are hoping that, next spring, we may hear from CMS with an approval.
And you use the data from the mental health report that the Sentencing Commission did in yours? That's something that I had started trying to get done, and I'm happy that that data is finally being used, because that data said that 28% of male inmates are chronically mentally ill, and 80% of female inmates are chronically mentally ill, disregarding substance use disorder. What is your goal there to provide services for those that have chronic mental illness that are incarcerated and soon to be released?
Thank you. So in the core services, we have transitional care management, and that will be able to help the inmates inside the walls to be able to utilize the services from the incarceration, as well as the warm handoff post-release. So looking at the services post-release to increase the reentry initiative in terms of making sure they are linked with maybe outpatient clinic that can able to have a host of services, such as helping with healthcare, primary care, as well as the mental health component there. So kind of linkage between when they're released from the incarceral setting to the community.
Can I just add one thing to that? So another example is that, again, this is why it's so helpful to have all the state agencies at the table. So individuals with chronic mental health conditions that perhaps had a pre-existing relationship with DEMIS will continue to have that relationship with DEMIS going out the door. And so, as Alexis said, the pre-release work, the transition care management, will reconnect those individuals back to DEMIS to provide services in the community upon release. And I just wanted to say one more thing, Senator Austin. The 10 million, that was just an example. That was not based. Okay, just wanted to.
I read that, and I
Okay.
just wanted to say, what are we putting in the budget to start it? Because whenever we start it, the best we can hope on is a 6 months in fiscal 25 that we may be able to start this. And I just have one more question, and then I'll get the chairs and the ranking members from the two respective committees. Someone on a timeline, someone gets arrested, they're DEMIS related mental health person that's soon to be incarcerated. They get incarcerated, they get a sentence of 5 years. And while they're in there, the services that are available are what we currently have, which is really nowhere near what we need. Does any of this waiver help during the 4 years and 9 months before they get to pre-release status help with any of the conditions that are happening while they are incarcerated.
I like to say that I did visit, I believe it was Osborne, a few months back, and the services that's already being implemented for the individuals incarcerated are amazing. They have a robust MAT program that's able to help individuals who have came in with substance use disorder, as well as provide MAT already for the individuals incarcerated. I believe that DOC, Judicial Branch, DMIS already have services that are really robust and prior to 9 days to release. And those services I've been able to see firsthand in my visit with them. And a part of this waiver is the Medicaid coverage will be 9 days prior to release. So that's where the difference is.
So I get that, but my question is, someone that's got chronic mental illness, disregarding sans substance use disorder, chronic schizophrenic, coming in non-compliant with their medication, as an example, getting incarcerated, going to Garner Correctional Institution as a level 4, level 5 mental health incarcerated person. What does this waiver help that person during their 4 years and 9 months of incarceration before the pre-release section of this waiver? I know the commissioner looks like she's coming up here. I think she sees where I'm going with this.
So while I would defer to my colleagues at DOC, this waiver is not designed for that purpose. So the answer, Senator,
Okay.
respectfully, is no. So the idea, as Alexis had pointed out, is that it's to be able to continue any services that an individual would have received while they were incarcerated. The challenge that we're having, and we can see with the numbers and the statistics that were cited, is the lack of continuity of care that occurs when a person is released from incarceration. It's adding to several things, right? It's adding to recidivism, it's adding to homelessness, and no matter what we do as a state, we are going to end up having to provide support and paying for the support of that person. So no, our responsibility under this waiver, as it is, well, it'd be more robust under the waiver, but now would start at the 90-day period.
Okay, I just want to make sure, because we have gotten through a public act that that was done through Judish, what corrections would need to handle medical and mental health care during incarceration. And right now, we're nowhere near the numbers for staffing to handle those conditions. So I just wanted to make sure that we were focusing on what this will do, recognizing we still have work left to do. If we're going to, someone goes 4 years and 9 months without the care that they would have gotten had they not gotten incarcerated. And then we want to make sure we're ramping it back up to that pre-incarceration treatment. So I just want to make sure that we recognize we still have that 4-year, 9-month period where we're not providing the level of care that we may need to be working up to.
We do, I almost said Your Honor, because I just feel like I'm back in court again, but.
I'm sorry.
You
I haven't
practice it.
started.
Oh, man. Okay. There's muscle memory. I'm not sure what happened there, but here's where we are. All right. So you're absolutely right, Senator. But I can say that much of the work that we did here was really informed by what is already happening at DOC. So our DOC partners were very instrumental in identifying where they believed that we could provide more enhancement of supports when a person was released from incarceration. And that is in part why these specific services in this waiver have been outlined.
Well, thank you. I think that corrections is doing what it can with the resources that we have given them. This is not their fault. We still have dollars that we have to get into the system to provide the resources that are necessary, in my opinion. So I'm not blaming corrections for this. When they gave us the list of positions that they needed and the dollar amount that was necessary, it's about $30 million worth of staffing that they need to ramp up. So I just wanted to get the timeline outlined. So Representative Paris? Any questions?
No, ma'am.
Representative Gilchrist, any questions?
No questions, just thank you for your work on this. I think it's very valuable for the state.
Senator Lesser?
Thank you, Madam Chair, and thank you to all the departments involved for their work. I know this has taken many, many meetings over a very long period of time, and appreciate the leadership that Commissioner Barton Reeves you've shown personally, but also I know that across your agency and other agencies, this has been a lot of work over a long time, and it's I think one of the most important policy that we're advancing in the state. So I'm very grateful for that. Can you just describe the budget neutrality piece that we have to show in the application, and sort of building on Senator Austin's question earlier, how that's likely, is it, I understand that's federal budget neutrality, but is that how that's likely going to impact us on the committees representing here?
So I'll do my best to explain. CMS encourages states to go through this exercise, as you said, on federal budget neutrality, where we have to look at costs, current costs, and what costs will look like in the future. And so through help from our consultant agency, they're able to put the numbers together and help us look at the fiscal impact of those numbers in the future. I hope I'm answering your question. So this federal budget neutrality, CMS knows we don't have that money. And so they're working with us to say, okay, it's hypothetical, as if you had the waiver, how much will it cost?
And the application before us suggests that this would save the federal government money, that investing in these services would pay for itself.
Well,
Senator? Yeah, they're asking about the same question you're asking about
Okay.
cost, so.
So thank you, Senator. As Bill Halsey had mentioned, we are still working through that's usually part of the implementation plan. So we will have more specific costs for you. One of the advantages of our being able to file the waiver is that we are already spending state dollars with no federal match for people who are due to be released from incarceration in the 90 days. So there will be an opportunity for us to actually reduce some of that cost because of the federal match. But and I apologize, but the specifics of that is so complex for us to gather that we really are still working on that right now. It took California about a year to be able to put their implementation plan together and to come up with a budget. It is obviously it's a much bigger state with a much larger population, but that should give you some sense of the complexity of that.
Thank you. We'll stay tuned.
Thank you.
All set? Representative Nuccio?
You see the way she's looking at me? She's really not happy that I'm back. I have several questions, but I'm going to adhere to the two until we get to the second round. First, I just wanted to ask specifically, you mentioned in regard to what Senator Lesser just said, that, you know, we're currently providing services and we're paying for those without a federal match. And you also mentioned the inmate exclusion excludes certain reimbursements for certain services. So how does this waiver change what we are currently providing? What is additional to what we are currently providing or paying for at the level right now?
So we are, and I'll have Alexis and Bill correct me where I'm wrong. We are currently paying for almost all of these services. I would say that we are providing these services to those who are incarcerated now. And as I mentioned, when I was responding to Senator Lesser, we are carrying this all at state cost. So there is an opportunity for us to have some federal match. What is really specific about this particular waiver is that it is focusing on the populations that we know have the greatest struggle when they are released from incarceration. So those that have chronic mental illness, substance abuse, issues with housing, and that really comes from the research that had been done with other states that have determined that while they cannot support the entire population of those that have been formerly incarcerated, there are specific populations that if you give them a certain degree of support upon release, then we are reducing the cost that we have that is related to reincarceration and the cost of providing treatment and the cost of not providing treatment for people who are unhoused. So specifically, Alexis, were there some that you wanted to speak to?
Yes.
Okay.
Thank you. So right now, 30 days prior to release, Medicaid is able to be turned on. So kind of backing up that timeline to 90 days will allow for that coordination of care to really happen. Because we know 30 days is a short amount of time. So backing up to 90 days will allow transition case management to be able to be streamlined through a handoff to a community provider, as well as a 30-day supply of medications in hand prior to release. So having that wiggle room to be able to really activate the services.
So just as a kind of nested with that, everything that you're saying there with the coordination of care and the medication and the first parts of this program that we, on slide 6, I absolutely totally agree with. Is the HRSN, are we currently doing all of those things on state budget? Because this is where I have more concern.
I'll defer Commissioner Reeves.
There's a bus and you're under it.
So much for being in court.
So Representative, I can get you the specific answers, and probably our colleagues from DOC might be better prepared to answer that question than I am today. So we do a little bit of health-related social needs in the 90 days before the person is released. The specifics of which I will defer to my DOC colleagues because I'm not as well versed in that. But what we have found in our communications with them as we're preparing that is that there are specific challenges, particularly when we are dealing with individuals that, and I'm also looking at slide 6, that have health concerns that include blood pressure, diabetes, Hep C, and HIV, and other health-related social needs. And housing supports really is the one where we find that there is the greatest need. I am not sure, but whether or not you've seen it, but there were some individuals who had testified with respect to the enormous challenges that they face after incarceration to find housing, that there are many landlords that will not house a person who has been formerly incarcerated. And so there was some legislation to try to provide some relief. But this continues to be an issue. And in the conversations that I have, I'll just say, quite frankly, in the hallways of our Capitol and here at the LOB, I do have a chance to speak with people who are formerly incarcerated, and they're living with relatives, and they're sort of moving from couch to couch, and they will eventually end up back on the street, and then they'll eventually, without resources, maybe end up being reincarcerated. So that specific one is really where we can, I think, get the most value from our waiver. And we found that to be true in other states as well. That's why there are 18 states ahead of us that are applying for the waiver, because this with the number of people that we incarcerate as a nation, and then the number of people who are released from incarceration, it is a challenge that we all need to face.
I agree. I do know that housing is a big issue for people who are getting out of incarceration across the board. I absolutely understand that. There's just certain parts of slide 7 here that I think are, I would love to be able to provide the seniors unlimited incomes in my town with generators and refrigerators and
Yes.
humidifiers and air conditioners and air filtration systems. Like, I just think it little steps a little bit far in that sense.
Understood.
I have one more question.
Just because you just got back, yes.
Okay, so the other question that I have then is, again, looking at these statistics, if you're saying 85% of 12,000 inmates are going to be eligible for this, you're looking at 10,200 inmates. Without having any kind of cost on this, I understand that it is federally budget neutral, but I would like to understand these expanded costs and the state impact on that, because, we're constantly hearing like this year, Medicaid is over, right? For multiple of reasons. And there's a rate study coming out that's going to look at increasing the rates of Medicaid. So this is an area that I think we've got an enormous amount of pressure on already, and not having any kind of fiscal note on this makes me automatically say I'm going to have to be a no, because I don't know what this is going to do to the budget. I don't know how many people it is. I don't know what the average cost is per person. Like, how do these expansions expand what we have? Is it going to be worth it with the break off? So for me, using these other states as a model, do you have any kind of inclination what this is going to be a cost per person? And if 85% of every single inmate that we have is going to get these high level of services like that, there is going to be a budgetary impact.
Yes, there is.
Yeah.
I do not have that number for you today, but I will work to get that for you.
I appreciate that.
Yes.
Thank you.
Okay.
Senator Seminara.
Thank you, Madam Chair. Good morning. Thank
morning.
you so much for your presentation. I do share Representative Nuccio's concerns very much. I have some questions of my own, though.
Certainly.
You mentioned during your testimony that you were hopeful that this waiver would be used for victims, that some financial, I'm not actually even sure what you were alluding to.
I can explain.
But
it to you.
I would love to have a little bit of more knowledge of what you mean. How will this waiver help victims?
Sure. So, and I'll ask Bill Halsey to come back up and provide some more explanation. So we are very much aware, and we've learned this from talking to our colleagues in other states, that when supports are provided for people who were formerly incarcerated, they were incarcerated because a crime had been committed. And we have a high degree of sensitivity to those who were victims of those crimes. And this is why the budget piece is important. With some of the savings and some of the reimbursement that we will get in the federal match from the state, there will be capacity to have more dollars available. And what we are thinking is with those dollars, and we actually have spoken to the Office, is it Victim Services? So, okay, well, in our discussions with the Office of Victim Services, that some of the money that we would be able to save would be redirected to the Office of Victim Services. That is our thought. And we spoke with them because we really wanted to understand what the impact of these kinds of waivers are in other states on victims of crime. That was the first thing. And then the second is that that particular office is also facing its own budgetary crisis because it is funded primarily through federal dollars, through, I would describe it as sort of one-time dollars that come from large lawsuits. And so there aren't as many of those lawsuits as there are in the federal dollar. Let's take, for example, tobacco money and other kinds of money that the Attorney General for the country would have brought. That money is actually placed in a fund, and then a portion of that fund is made available to Office of Victim Services in different states. But that fund is declining, and there really is no specific plan to continue to fund that organization because it's federally funded. So our thought was that with what we could have from this waiver, we would be able to redirect some of those resources to the Office of Victim Services.
And what would the Office of Victim Services do with those funds?
Yeah.
That's
They would
what's
actually-
unclear to me.
Yes, I'm sorry. They would continue to provide the support that they do now. And that is that they usually provide direction on counseling support, victim services. Sometimes it's restitution by the person that actually committed the crime. And then they also provide resources, and I would call them warm handoffs to the victim so that they can get services in other places, because we have the Office of Victim Services. We also have the state chief public defender. There are lots of offices that are available and support victims, but that's what the Office of Victim Services does. So once a person is a victim of a crime, which is wholly unfortunate, that office is charged with helping them to get the supports that they need. And they usually do that in conjunction with the Office of the Victim Advocate as well. So our state has two.
Okay.
Okay.
And then this is obviously a service expansion. And do we really expect 90% cost mitigation of all of it? That's
So that is what CMS has provided to some states. So our usual Medicaid reimbursement rate is somewhere between 56 to 62%. The 62% is on the high end. But we do have some services, and I'll defer to Bill, that we do get a 90% match. And during the pandemic, we did get a 90% match on much of the spending that we incurred under Medicaid. So the specific match that we would get would be determined by CMS.
so you're not exactly sure, though.
Well, no, because that's determined by CMS. So it wouldn't be responsible of me to say to you, yes, there is a 90% match. We did provide an example just for illustrative purposes, but we couldn't say for sure that that's what CMS would do.
Okay, and then I have, if I'm allowed indulgent, one more question.
Just one,
Okay,
but you haven't been gone as long as she has.
I know, but I've been here.
That's not an excuse.
It's okay. Senator, I'm sorry, if you don't mind, I did get some clarification from Bill Halsey, who's our Deputy Medicaid Director. He said a majority of the individuals who would qualify would be under Husky D, and I can ask him to come up and provide more explanation around that. And our Husky D is at 90% match.
Okay. And why are we starting this 90 days prior to release? From what I understand, we provide these services already, correct? So why not start these services upon release? I can understand giving them prescription medication upon release and having them come back into the community with their medicines, because I think that's very important. But I want to understand why we're starting this process 90 days prior to being released, rather if we're already providing the services.
Yeah, if you don't mind, I'll have Bill respond to your question.
Sure, thank you.
This might cover a little bit of the budget neutrality question as well. So I'll just focus on DOC for a second. And so if you take the three services that were required to cover under this waiver, the transition care management, the medication assisted treatment, and the pharmacy. Those services, as you said, we're paying for today with state dollars. And so if you start Medicaid 90 days prior to release, we can capture the costs that we're spending today with state dollars for DOC. And this is part of our budget neutrality submission in the application, that we've asked them, and this is preliminary, and this is the work that we really need to dig into, but we've asked them to identify how much are you spending on any transition care management services, on any MAT, and on any pharmacy 90 days prior to release. And all of that becomes Medicaid eligible under the demonstration waiver. And now all of a sudden we're bringing in new federal dollars under Medicaid now that those services are reimbursable under Medicaid. And those federal dollars now become a reinvestment opportunity for the state for things like housing and additional community-based services that individuals need. So the 90 days is as early as, or the most that we can probably get under CMS. So what we're trying to do is capture as much federal revenue as possible to reinvest back into the service system. And so by the 90 days, those are capturing costs that we're incurring today, state dollars only, and that's the whole reinvestment strategy.
Okay, I appreciate all your answers. I'm still very concerned about a number of issues, but I appreciate your candidness. Thank you so much.
Thank you. Up next is Representative Nolan.
Thank you. I just wanted to rewind a little bit as far as the service of transitional care management. And I understand that a question was asked about the why the 90 days. And, basically it's for transition planning, access to service, stability and support, and helping reduce the recidivism of that person that's leaving. I'm just interested on some specifics in regards to follow-up for when they do leave, because that seems to be the concern for a lot of people that are trying to help, trying to advocate, and trying to ensure that there is a continuation of help. So can you be specific on the follow-up and knowing the communities that it takes a little bit more time for people to get appointments once they leave? So I know that's another benefit for the 90-day transition. So if you could just give a little specifics on how we can ensure that follow-up is something that we don't have to worry about.
Thank you.
That's,
Go.
that's a great question, because in our weekly meetings, we're talking about implementation. And the hopes is that the external providers will come in, hopefully it's inside the incarcerated settings, to meet with the inmate. Hi, I'll be seeing you after your release, and kind of follow them through and that warm handoff, as well as kind of the idea of having this kind of helicopter approach where someone can follow the inmate from when they leave the incarcerated setting to the outpatient clinic or wherever they are referred to, and how to make sure they get there. So if there's a follow-up calling, making sure there's maybe a hub that's implemented into the approach between when they leave and when they're out back in the community.
Okay.
So more specifically, Representative, our vision for this is to use the resources to hire community health workers, because we already have an opportunity to do that. And last session, we because you were able to pass it, we are able to get Medicaid match for community health workers. And we're specifically looking for community health workers that have lived experience. And that is where you'll have an opportunity to have the warm handoff. And as a component of this, there's also case management. So our vision is that the case managers who may also be the community health workers, and sometimes they're the same person, sometimes it may be a different person. That's where we are envisioning, this is how other states have done it as well, where there's an opportunity for there to be some assurance that the person is at least led to the services that they need, follow up with them. Of course, it's up to each individual as to whether they participate in that service, but what we're finding and what we've learned in talking with other states is that where there is a person that is essentially assigned to you as your navigator, that the ability to engage regularly and consistently and get those services is much higher than just having a person come and see you once when you're about to be released from incarceration. That's okay. About to be released from incarceration, and then really left to find these services on your own in the community. That tends to not be a successful outcome for the formerly incarcerated.
Okay, thank you. And you brought up a good point, that lived experience, and with the navigator.
Representative Nolan, we can't hear you back here. I'm sorry. Your mic is the mic on?
Yes, I'm just not close enough, I think.
Okay.
And that lived experience that you talked about that you're looking for in regards to those that are out there that are going to provide or help be part of that, providing that situation and experience. Can you talk about how we are recruiting to get those lived experience persons? And can you speak a little bit on the navigators that are out there actually doing the work now so that people can understand what is part of that?
Sorry, no, I don't have my mic on. Okay, so once we have the approval from CMS, then we'll be able to actively engage with recruiting the navigators. Well, we have spoken to some navigators who are actually engaging in the work now. They're explaining to us that it's really important to start that while the person is still incarcerated in that 60 to 90-day period so that they can build rapport and have a relationship. And then when the person is released, there'll be a much larger implementation team, which will include all of the people and all of the state agencies that we spoke of, that will then set up a care plan for that individual. And that will be specific to the needs that they have. So if we have a person that has substance abuse disorder, they may have chronic mental health services. They may have a need for chronic health services. They may also need housing, or sometimes it's a constellation of those services that they need. So that need will be determined and examined by that community health worker. And then it will probably be through other community action agencies and other agencies that we'll be working with. I shouldn't use that, it's a term of art, but other community-based agencies, let me use it, that's a better term, that will be able to help us to identify and work with people. So we know that there are already a number of agencies in our state that are helping people that are formerly incarcerated. And our plan is to continue to work with them. And perhaps they can also hire those community health workers that we're speaking of to do that work. So if you were to read the implementation plan from California, it's very complex, and it's very complex, and it requires a lot of lifts from many agencies. But on a high level, that's the idea: is to get the health worker, get them working with the soon to be formerly incarcerated person, create a plan for them, identify the community supports that they need, and then help them to access those supports, and then follow up with them to make sure that they have what they need in order to access those supports successfully.
Okay. And you talked earlier about a 30-day supply of medication. Is 30-day the max, or is it something that can be extended to more than 30 days because of the long
Oh, I
time?
believe they can't hear you again,
I
Representative.
can't, yeah, I'm sorry. I know you're a soft-spoken person, so I get it, but I'm an old person. I cannot hear you.
So you talked earlier about the 30 days for the medication.
Yes.
Thank you.
Sometimes appointments are not able to be met within that 30-day period. So sometimes the need for medication to be a little longer, because I know, like, for my prescriptions, I get up to 90 days now.
Yes.
So because that is a change in regards to the medication that we give out, is it possible to extend it more than 30 days so we can ensure that that person has the medication they need after 30 days, or can they re-up if they need it in that because of the possibility of the need, are they able to re-up right away, or is that something they have to go through a whole process?
Well, fortunately, we hope that they don't have to go through a whole process for that. So the 30 days is the initial amount of medication. So the person, especially if they're on a medication for some, let's say something like high blood pressure, or they need a specific medication in order to make sure that their mental health is stabilized, we want to make sure that they have that as they're being released. Certainly, it can be extended because let's remember that these are also Medicaid recipients. And so there are other parts of the Medicaid program that would allow for the expansion of the number of days that they would have available for medication and other services. But yes, of course, we would not have someone lapse in their medication and risk their health in that way.
Okay.
You already are on 3. You know that. I do know that. You're all stretching.
Well, I don't think you could hear my other question.
I couldn't hear.
Don't worry, the rest of us are keeping count too.
I couldn't hear what you were saying, but I saw that you were speaking. Representative Dillon, 2 questions, ma'am.
Are we using the Nolan rule now?
No,
Thank you very much for your presentation this morning. This is so exciting. The correction system is a health system, and this policy really it predated Medicaid. So it's so exciting that we're doing this. I have a question about women in corrections. And in a way, it's a DOC question, maybe. Does this alter or modify in any way the codification that we did of the West Consent Decree a couple of years ago?
I don't know the answer to that questions, Representative, but it's not intended to change any specific legislation that is already passed by the legislature. It's just intended to be a supplement and an expansion of services and a way for us to maximize federal match for services that we are already providing. But I can try to get you a specific answer to your question.
That would be great. I know people have other questions, and we can discuss that offline. In your research to develop this, and it's so exciting that you're doing this, I can't overstate that. Did you look behind the data that has already been accumulated on the delta between men and women in the distribution of disease in the system? Do we have some kind of a framework to understand how it could be, and that could inform services that we provide as they leave?
I don't think so, Representative. I don't believe that we actually did that we dug into the data deeply to determine the differences in the services that are provided by gender. I think we just specifically looked at just the overall incarceration rate and the conditions that people have who are being released from incarceration who would be covered under the waiver. We could certainly look at that more deeply. I'm sure that we have it and we could figure that out.
Well, maybe I wasn't clear. The question was the distribution of disease. Why are so many more women? Why do they have a particular diagnosis more likely than in the male population? And it wouldn't necessarily be challenging the services that are being provided. And it's been a while since I've been up to McDougall, but I've always been excited and impressed by the mission-driven people in the correction system. So I have no criticism of them. Very often the problem is us. And so I have no criticism there. But if on the distribution of disease, why do so many more women present with a particular diagnosis than men do?
Yes, I know, Representative, we did not do any further analysis as to why there's a difference in the presentation of particular diseases and conditions based on gender, but I can see if our our DOC colleagues may have some more data that might be informative, but I don't have that today.
Thank you. We wouldn't have time to do justice anyway, but I think it's something to think about. And Again, thank you for your hard work.
Representative Belinsky.
Thank you, Madam Chair. I appreciate it. This is an interesting conversation. And many of my questions have been asked and somewhat answered at this point, but if I might just start by saying to Commissioner Barton Reeves and Mr. Halsey and the entire organization, the work you do is so important, and it is so underfunded. I just don't know how you guys can keep smiling as we continue to try to put out a forest fire with water guns. So thank you so much for your work. My questions about where the state fiscal impact is have been asked by Representative Nuccio. I'd like to focus on something just a little bit different, which Senator Seminara started to sort of address before. Victim services, and I realize, and Madam Chair, you can steer me if I get off topic, because I really do want to tie this back.
I will.
Thank you very much, ma'am. From a victim's services standpoint, OVS suffers from just as large, if not a larger, budgetary constraint, and if I might characterize it, they're critically underserving victims and their families. And I know this firsthand personally, but I look at this from an appropriations perspective, and we're really serving nobody particularly well, and it's a budget problem. But as a state of Connecticut, from an appropriations seat, we have a $25 billion, give or take, budget that we're administering every year, and every year we have these conversations, and they are very, very difficult conversations when you think about the impact. So, Madam Commissioner, can you please tell me what's being done above my pay grade to have real conversations that involve every stakeholder from the governor on down about the fact that we're not deploying our appropriations resources necessarily to areas that are critically in need of being addressed. And again, I'm going to position the victim services portion of it as a personal priority of mine, but I do recognize the mental health issues that are existing in our correctional facilities, and they concern me deeply, because the last thing I want to see is somebody who has a serious mental health problem, set out on their own to fail and become a recidivism statistic. So, we have a finite amount of money to spend as a state. $25 billion is a lot of money for a little state. We need to make some pretty tough budget decisions. Commissioner, is there conversation going on above my pay grade that puts this out there as far as how we holistically look at our budget to meet the needs of every person in the state of Connecticut that that is here and needs some sort of support?
So is that a question for me, sir?
I'm not certain.
I would
Chair.
say
I guess what I'm trying to do is, I guess ultimately it is a question for us in appropriations.
Right.
I'm trying to cheerlead the commissioner into making this so much of a bigger deal than just a budget battle.
I think that the commissioner's doing a pretty good job of cheerleading the justice waiver, and I look forward to budgetary conversations with you on appropriations as we choose where our state dollars will be going. So, any other questions, Representative Belinsky?
No, nothing that's going to add to the conversation. I appreciate the consideration, Madam Chair.
Thank you. Up next is Representative Hughes.
Thank you, Madam Chair. I would love to have my sister social workers just explain a little deeper, building on Rep. Nolan's questions, how important transitional case management is, and maybe you could liken it to the way we absolutely require that for folks leaving a hospital setting or an institutional care setting. What is transitional care case management, and how critical is that in this transition?
As long as we're talking about the justice waiver.
In the justice waiver.
Thank you.
Yes. No, I wanted her to.
I know, I get it. I'm just trying to focus us back on the justice
Yes.
waiver.
Yes, as a experienced social worker. Go ahead.
I just want to introduce myself again. I'm Alexis Mohammed, LCSW. And that's a great question because as we know in the incarcerated settings, the transition out is very important because that will set up the person for success or failure. So really looking at that case management to be able to highlight the strengths and the needs of that person and how they'll be able to effectively succeed when they leave the incarcerated settings. And so it's very important, all those 90 days, a lot can happen in 90 days for that warm handoff into the community.
Thank you. That's all, Madam Chair.
Thank you. Representative Harrison?
Thank you, Madam Chair. Can you let us or explain to us the other waivers that have been submitted by other states? How does ours compare to that? And most specifically, how does ours compare to those waivers with these health-related social needs? I can understand what you're saying about housing, but then we add in all of these other things. My concern, I represent the largest population of seniors in the state of Connecticut who do their best to get a small cities grant to put a new window in.
Thank you, Representative. I'm actually going to have Bill Halsey, our Deputy Medicaid Director, answer your question. We did do an extensive amount of research on other states, but I'll have him answer that specifically.
Thank you, Commissioner. This is a great question. So thank you for that. One of the things that we heard very early from our consultants and CMS is if you follow the waivers that have been approved, California, for example, it is very likely that they will review them in a more expedient manner than if you try to introduce new concepts, new ideas, new thoughts into the waiver application. So we really stayed very close to the California waiver application because that is the only one that was approved when we really started the application. Since then, Washington has been approved and Montana has been approved. So, and we're not, I think, giving up anything by following the California model. They asked for 90 days. I don't think any state's going to get more than 90 days. Their three core services, the transition care management, MAT, and medication, that's in their waiver. And then in the Washington, they did introduce the health-related social needs. They went a step further and used the health-related social needs to an expanded population. We are just focused on the justice-involved population for the health-related social need component of the application. So again, we really tried to follow what has already been approved by CMS in the hopes that that will speed up the process.
Thank you, but I don't think you specifically answered my question, which was, how do we compare with the amount of things that are listed here for social, health-related social needs in comparison to those other states?
The applications that we have seen so far, we are aligned with the other waiver applications.
Thank you, Representative. We have not asked for anything more than the other states have listed. So everything that you see here is directly modeled after all of the other states that have filed a waiver. So the only thing that we've done that might have been different is we've been just a little bit more specific about what we mean by health-related social needs. Some of the states have just kind of bucketed that into, let's say, medication or housing. And we noticed that some of the states were more specific about that. So we wanted to add that as an opportunity for, quite frankly, to make sure that CMS understood what we meant by health-related social needs. And that's why that part of our application is more specific. But it compares in the sense that it is almost identical to every other state that has applied for the same waiver. We've only provided a little more clarity around what we meant by health-related social needs.
Anything else, Representative?
I do. I have a second question. So you talked or spoke briefly about victim services here. And while I think that it is a good thing that we want to make sure that we give treatment to people who are coming out, because we do know, health related as well as mental related outcomes, taking care of those provide better outcomes. My concern, though, is what are we doing for the victims? You sort of briefly touch on it, and yet we could have victims who are out there suffering from the same or requiring the same needs, and they get nothing.
So thank you for the question, Representative. I think I would respectfully disagree with you that they get nothing. We do have two offices. We have the Office of Victim Services and we have the Office of the Victim Advocate. There are also services that are available extensively through our Department of our DMIS is how we refer to them. So there are victims that do receive an array of services through other state agencies, not necessarily through this waiver. But our point is that through this waiver, not only will we provide the services as you described, but I think we have learned that through other states have done this as well, but we have raised this up in our waiver specifically to answer your question from before about what's different, is that we have pointed out in our waiver that we would like to use some of these resources to be directed to victim services. And that's not necessarily something that other states have done. Their waivers have been specifically for the services for those that have been formerly incarcerated. But for us, we made a determination that we needed to do more than that we needed to be very specific about how we would use some of those resources. So I would actually defer to the Office of Victim Services and the Office of the Victim Advocate to be very specific about what it is that they provided. But I will also tell you that many years ago, I did sit on the advisory committee of the Office of the Victim Advocate in particular, and they have a wide array of services that they provide. And those have been provided for years, and so has the services that are available under the Office of Victim Services, in addition to the supports that are provided by the state's attorney, which often is an advocate for those who are victims of crime. So they do receive services, but to the representative's point earlier, we're a small state. There are many needs that need to be met, but the victim services are available.
All set, Representative?
I guess so. I could probably go on, but that's my two. Thank you.
Okay, thank you. Representative Johnson, 2 questions.
Thank you so much for the reminder, Madam Chair. So I just want to thank you so much for your great work in this waiver. And this is something that's very, very important for our communities. And so my question has to do with the process. In terms of the discharge from the jails or the institutions and moving them into the halfway houses, how do we gauge the 90 days? Is it from the institution to the halfway house, or is it from the halfway house into the community? How does that process work?
The 90-day period begins the 90 days prior to the release from incarceration. So that's the period that we're counting. And that was the period that our Deputy Director Bill Halsey was referring to. That is the maximum period that has been permitted under CMS under the approved waivers that allow us to maximize federal match for the services that we are already providing as a state for those that are being released from incarceration. So that 90-day period starts then in terms of when we begin to provide the services, and then the case management can continue after that.
And in terms of when they go to the halfway house, this has nothing to do with the halfway house then. Just want to be clear.
That's right. The halfway house is just one of a number of services that are already being provided.
Okay, thank you so much. Thank you, Madam Chair.
Thank you. Representative McCarty?
Thank you very much, Madam Chair. I appreciate it. I'll be very quick, very brief question. Commissioner, are you able to say, so I'm looking at this as a waiver and it will need to be approved as it goes forward, as it is a waiver on the original substance use disorder waiver. Is there any impact at all on this waiver application? Does that impact the original waiver in any way?
No, it does not.
Okay, I just wanted that confirmation. I thought that was the answer. And then secondly, I know it's a little premature, some of the other states that have asked for this consideration, but do we have any evidence or any data from the states that have already applied and received the waiver, if that in fact helps with reducing costs, and I'm looking at emergency visits to hospitals, also some other areas that may be cost saving? If you would just maybe talk about that piece for one moment.
Well, the waiver is very new, so there's only anecdotal data that's available right now. There isn't anything that we have seen that's actually been published. So we can certainly go back and talk to California, which is the first state that has had approval and implementation of the waiver. Just anecdotally, this is very anecdotal. I mean, they have reported that they're seeing rather lower rates of recidivism, which is really was their ultimate goal. And they're seeing, again, very anecdotally, lower rates of homelessness, right? People being unhoused after having been incarcerated. California is a very different state in the sense that, those that are, it has a very large unhoused population. So sometimes it's hard to sort of break that out between people who were formerly incarcerated and people who may be unhoused for other reasons. So, and they're also seeing, and this is just from seminars that I've seen and other talks, that the person who actually started and implemented their program, that they're seeing more engagement from their community partners in supporting those that have been formerly incarcerated. And also just doing some more work to just build up more resources within the community around housing, which is not just benefiting those that have been formerly incarcerated, but just it's benefiting the community as a whole because the housing is built and then it's made more available. So that's just what we know anecdotally. We can certainly go back and see if we have any specific data, but again, the program is so new, I'm not sure they'll have anything that's been reported, but we can certainly go back and look.
Thank you for your comments.
Up next, Representative Dathan, also 2 questions.
Thank you for the reminder, Madam Chair. Thank you so much for your presentation this morning. In reviewing your testimony and on page 8 of your slide deck, you have adults with intellectual or developmental disabilities highlighted. Are there criteria that the state is using? Because I know when we've talked to our DOC, they haven't sort of a system in place to determine if people have an intellectual or developmental disability upon intake. How are we going to ensure that maybe people who haven't been identified as part of that are able to get these services?
Well, thank you for your question. That is part of the reason why it's so important to have sister state agencies as partners. The Department of Developmental Services does have a tool, has a number of assessment tools, as you know, to determine whether or not a person meets the definition of a person that has an intellectual or developmental disability. So our plan under the implementation would be to access those tools to make that assessment so that we can use the same criteria that we use now for determining whether a person is eligible for services with DDS.
Great, thank you so much. I'm looking forward to really seeing that in action. My second thing is more of just a comment. I know, the U.S. Department of Justice has highlighted ongoing reforms to reduce recidivism, and this waiver is specifically highlights those options that are helping to reduce recidivism. A lot of these things are what we see in some European prison systems. And if you look at the correlation between getting these services and the rate of recidivism in those countries, it is very low. And we all know that when you are receiving substance use disorder or medication for mental health needs, they take time to really, titrate up to a working order. So this 90-day period allows those people to make sure that they are getting the medication they need, they're getting the services they need, and therefore feel part of the community. So I just want to commend you all for putting this waiver forward. I think it's extremely important for our state, and we know how much we pay as a state for incarcerating people. We pay more to incarcerate them than we do to educate them. And that is really something that we need to address to ensure that folks coming back into our community feel part of our community so that they can succeed. So that's it. Thank you, Madam Chair.
Thank you. Representative Butler, you had your hand up before. Senator Berthel.
Thank you, Madam Chair, and good morning, Commissioner. Thank you for your presentation. I was in the car listening to some of it's on my ride up from my district. I just want to make sure that I understood clearly actually the question that Representative Nuccio asked before with respect to the impact on the state budget. At this point in time, we do not have an understanding of what that would look like. Is that correct?
That's correct.
It is.
We don't. Yeah.
I'm sorry, thank you.
Yes.
And if I understood correctly as well, listening from the car, that we anticipate there would be approximately 10,000 persons that would be formerly incarcerated persons that would be eligible for services under the waiver.
That's correct.
Okay.
Yes.
All right. So I think I have the same concern that Representative Nuccio did, and we share the role of ranking members on the Appropriations Committee, is that we have a huge unfunded component, unfunded mandate, if you will, as a result of this. And I understand that we have the federal match and we have, all of these other things that will come along financially. And I also understand, listening very intently, the why we feel we need to do this. Okay. And so I think that there will probably be some of us that will vote no on this bill today because of the unknown fiscal aspect to the state budget. And I don't think that necessarily suggests that we don't agree with the intent here. Okay? And I just wanted to be on record with that we always have this, we encounter this problem quite frequently, Commissioner, as you know, in Connecticut with the way we have to do things. But thank you for bringing this before us, and thank you for the answer to the question. Thank you, Madam Chair.
Thank you.
Thank you, Representative Paris.
Thank you, Madam Chair. Commissioner, thank you so much. Ms. Mohammed, thank you for being here. Two questions, but I'll make it as quickly as I possibly can. The health-related social needs, which I think is critical to the onset of our wraparound services that we provide incarcerated communities as they are going back into the present world as we know it, I think is critical. I mean, you're looking at about 10,200 people which will need services, because that's about 85% of the 12,000 that will be eligible. Now, for me, and I think for other colleagues, this seems like almost a no-brainer. There's no risk and there's high reward. And I believe, quite frankly, in my personal opinion, and I'm not an Ivy Leaguer, so bear with me, but if we don't get the waiver, it doesn't mean that we necessarily have to approve from this committee any of those costs to go towards any of these services. So for us to explore this as it being a no risk, high reward opportunity for our state, not on the backs of our taxpayers, and also being able to provide health-related social needs for 10,200 people, which would also include housing needs, which we are already in a housing crisis. And we talk about having that opportunity to help out our sister agencies. I'm sure the Department of Housing would appreciate that. Just makes a lot of sense to me. But as I'm already confident, and I'm going to put this into the universe and manifest that we're going to get this waiver, the implementation is probably the most concerning part for me. I know that you all are working diligently to ensure that the implementation does go off rather smoothly. First question is, what are some of the challenges that other states, and I guess it would only be California in this sense, what have they faced in terms of their implementation of this program? And then also, in addition to that, the second question will be, how far in advance have you all begun working on the implementation and thus send to CMS and the federal government to begin to work on behalf and in tandem with you? Thank you.
Thank you for your questions. So I'll start with the challenges around implementation. So other states, and there are some that are still, there's 18 that are still waiting to actually have their applications approved. I would say from what we know, again, very anecdotally, it is really the coordination of services with a number of their sister agencies and community-based organizations. Not because there's a lack of cooperation, but because it's just very complicated to do. So they are working through that, which is why it can take a long time for an implementation plan to be pulled together. What I can say here is that we have been really very carefully thinking about implementation as we've been building the waiver. So that is part of the reason why you see some of the services laid out in the detail that you do, because we're thinking, well, who's actually, as Alexis had said earlier, Ms. Mohammed, who's actually going to go into the prison and the jail and speak to someone? Well, we think that should be a community health worker, and that individual should be a person, to the extent that they can be, with lived experience. Well, which community-based agencies are already providing services to people who are formerly incarcerated? And we have a pretty extensive list of what those are. Our partners at the Department of Corrections have already said to us, well, when folks are released, these are some of the challenges that we see that they experience, right? They have trouble re-engaging with their families and re-engaging with their community. They need an opportunity to find a job. So then how can we build that into our implementation plan? So right now what we have is a pretty comprehensive list of the things that we would build into the implementation plan, because we really tried to be thoughtful as we were putting the waiver together. So we were thinking not just linearly, but really in parallel. So I think that's the first part. So that probably answers your second question first. So other states have also run into the same issue. It is quite a heavy lift. So then how do you do that? And so part of their challenge that they've tried to accommodate is really talking to their community-based organizations and their partners as frequently as they can and getting their input and their feedback. So, and we've started to do that with, not just because it's required to file the waiver, but really, again, really thinking very prospectively about talking to who our community-based partners are and getting feedback from our stakeholders. So that part has already been, it's been done in one phase, and we plan on continuing to do that in other phases, because we've learned from other states that really is where the challenge is. And then the last challenge is really putting together the implementation plan itself, which is many, many pages. It's quite complex. Having a budget that is that's aligned with each segment of the plan, and making sure that we as an agency internally and our sister agencies have the people and the resources that we need in order to make sure that the implementation of the waiver is executed the way it should be, because it's the state's single Medicaid agency. We are ultimately responsible for making sure that this is executed the way that it should be. Our Medicaid department is, because we are a small state, but it's much smaller than some of the others in much larger states. And it's also larger than the one in Montana, as an example. So everybody has its own challenges, but those are some of the challenges that we face. We've been thinking about them ahead of time. We've been trying to work on them proactively. And that's where we are as we speak today in filing the waiver.
Thank you, Commissioner. I appreciate that explanation. I have other questions, but Madam Chair, I'll wait for my second time. Thank you.
If I could just, sorry.
Go ahead.
Please add, Representative Paris. Since I've done this waiver, and that's been June of last year, we've gone through maybe 5-6 renditions of a flow chart and how services will look like. So we're working diligent to make sure that we eliminating any foreseen factors, barriers that may happen in terms of implementation plans. So we work in the flow chart system, and so every day we're looking to see what we can do better.
Thank you so much. Thank you.
Up next is Representative Porter.
Thank you, Madam Chair, and thank you, Commissioner, and thank you to your team. Great job today with this presentation. A couple of questions that come to mind. Thinking about how we will evaluate the outcomes, right? So just wondering what type of data will be collected and who will be doing the evaluation of that data.
So thank you for your question. So the evaluation is a really critical component of this. We have some thoughts as to how we might begin, and as we build out our implementation plan, then we'll have more details. From a very high level, obviously, we will be collecting the data of the individuals who will be released from incarceration within that 90 days, and really understanding what the conditions are that they will need in order to be successful. So that really means that we're very specific about what our intake looks like. And as Alexis referred to earlier, as we have our flow chart, part of that flow chart is what really should our intake form look like as somebody is coming in? Because the intake will allow us to track what the evaluation will look like afterwards. So if we're defining success for an individual as you're released, if you, let's say you need behavioral health treatment, you go and you get your medication so you're stabilized. You then have a provider that you are navigated to with your community health worker. That provider then sees you regularly. You have an opportunity to then achieve some success with that provider. You secure housing and then you secure some sort of employment. That would be considered a specific successful outcome for that person. We would be tracking that evaluation. CMS also has very specific criteria that they use for evaluation as well. That would take a whole other hearing, quite frankly, to outline all of the criteria that CMS has for evaluating 1115 waivers. But part of what we would do in terms of our own evaluation would be able to use that data that we collect so that we could collect it not just for ourselves, so we could come back and report, but also to be able to allow us to report on our success in the 1115 waiver. So there's an entire evaluation system that's already built in.
And that's great. I like the fact that you're talking about reporting back. I'm just curious as to, with that detail, would you be open to including information, family members, community members, even reporting back to DOC, right? Because we're talking about 90 days prior to their release, right? Pre-release. Because I think some of that information would be pertinent and quite critical to even what they do before they're coming home. I think that would help them with what they're dealing with. And not really another question, but just I will agree with Representative Paris and speak those things that are not as if they were. I am praying that this is something that we will be able to do. And I know there's been some concerns, and rightfully so, expressed around budgetary issues, funding, where the money's coming from, that kind of thing, the cost. But I think the other thing that we need to equally talk about is the savings, right? You've continued to talk about how this will reduce recidivism, right? So that's a public safety issue. This will impact New Haven Police Department, Hamden Police Department, what we'll be able to do with those saved resources and time that's spent on crime, right? If we can get crime to go down, and I believe we will, because we will be addressing the issues that actually help to exacerbate the reasons why crimes are being committed. And I also think around the housing issue, it's important, and Connecticut has almost 600 barriers, right? When you talk about reentry, and the top two are housing and employment. And you can't have housing and you cannot have employment if you're not well. And I think that's the big thing we miss when we talk about reentry, that we don't address the needs of the individuals coming home that may not necessarily be so transparent to any of us that may encounter them. But there's damages that are done. So I see this as a way of rectifying those damages and bettering not just communities, but families and our economic status. If we can put these folks to work, get them on a tax roll, keep them out of prison, it's more than a win-win. So I really do want to thank you all for the work that you're doing. It's very much appreciated, and I think it will have great rewards for this state once we get it done. Thank you, Madam Chair.
Thank you. Up next is Senator Gordon.
Thank you, Madam Chair. I'll limit myself to two questions to be very brief. Thank you, Commissioner, for the work you're doing in the presentation. A lot of my questions have already been answered. But I just wanted to seek two questions for clarification. One is the presentation and what is being proposed. Is this an expansion of services beyond what's currently being provided to this population in the state of Connecticut?
It is, I don't know if I would characterize it as an expansion more than an opportunity for us to capture federal dollars for supports for things that we are already doing. So that's part of it. The expansion piece would probably be around housing and case management. So those are happening in very limited ways and in pockets, depending on which community you live in and what services and supports they have for you as a formerly incarcerated person. So with this waiver, what it would do is it would actually consolidate those services and coordinate them in ways that we're not doing now under the waiver. And we're not doing that in part because the services are not always necessarily coordinated statewide. And we don't get any federal match for that. So there's a limitation in the resources that are available to do that. So in many ways, it drives down some of the costs because we can get some federal money back for things that we are already doing.
And thank you. So it sounds like there is going to be added or expansion of services. And the next question I wanted for clarification is certainly understand a need to see what we can do to address things for this population. And I appreciate the work that that you're doing and your agency is doing. But we also have a lot of competing needs with limited resources, especially money, when we're talking about law-abiding, hardworking people, low-income families, seniors on limited income. And we don't know the cost. Is that correct? You talk about very anecdotal data or information about the effectiveness of this program, but it sounds like to me, and I wanted to see clarification, do we know what the actual cost to the state of Connecticut will be if we get a waiver and if this program were to be implemented? I'm a little unclear on that.
Thank you for your question. No, we are still working on building the budget for the cost. Our opportunity, well, let me just say, our opportunity to file the waiver that we're asking for today is a chance to just get the waiver in front of CMS while we build out the implementation plan and the budget. Because we will probably be the 19th, maybe even the 20th state at this point. We do think it's going to take at least a year, if not longer. And during that time, our state will still continue to pay for many of the services that are proposed in this waiver with purely with state dollars. So what we're really asking for today is an opportunity to seize the opportunity to at least get in front of CMS to have our waiver at least reviewed and hopefully approved by them. And because of the way that our legislature, our statutes are defined, we have to come before the legislature in order to, as you well know, in order to even have permission to file the waiver. So that's really what we're asking for today. So no, we don't have those because that actually comes in a later stage of after the submission of the waiver. And so we have to do that, but we're continuing to work on building those numbers.
And I appreciate the answers to the question. And a no vote doesn't necessarily mean that one is opposed to the overall idea of what's being done. It would just mean, in my case, that one doesn't want to put the cart before the horse and wants to make certain we have some really big questions answered before we march down a certain road that could cost a lot of money for the state of Connecticut, potentially. Thank you, Madam Chairwoman.
Thank you. Representative Santiago.
Thank you, Madam Chair, and thank you, Commissioner, for being here today and talking about this waiver. I just have one basic question. The folks going through this waiver also receiving services and language appropriate services. And I'm hoping that they don't get left behind. Only because the shortage of bilingual providers is felt throughout the state. Is there a guarantee within this waiver that the folks that need bilingual services are being served, especially with the wraparound services, mental health services, which we have a shortage of counseling and psychiatrists and all that kind of mental health services? And this would be a barrier. So is the waiver going to be addressing this?
So thank you for the question. Yes, the waiver will address that. Part of the implementation plan with respect to the community health workers that we're identifying as the navigators will be to recruit those that are bilingual, primarily Spanish speaking, We do have other individuals who are incarcerated now that do speak other languages, and the idea would be to also try to recruit individuals who are fluent in those languages as well.
And that would be including mental health providers.
To the extent, and your point is very well taken, Representative, to the extent that those providers are available, yes, that would be the plan. But as you said, there is a shortage of providers and services in the state, and it's actually nationwide. It is not unique to us here in Connecticut, but we will continue to do the best that we can.
Okay, great. Thank you. Thank you for being here. Thank you, Madam Chair.
Thank you. That's all I have down for the first time. Representative Nuccio has a couple of questions on the second go round.
Thank you, Madam Chair. And I'll try to kind of go through these quickly. So in regards to this waiver, I'd like to understand what it means for the under 18s and how do the HRSNs work specifically with the youth populace? Don't go too far.
This too, but in terms of the youth, what we've also heard from judicial is that it's the youth and their families are also struggling with housing, similar to the single adults. So they also have some have challenging housing situations, and they would be eligible for the housing supports if they needed it.
So they don't have to have any of the qualifying. So any youth person that is incarcerated, their family now gets access to
The youth.
generators, et cetera.
The youth, they have to be, the youth has to be eligible for Medicaid. And then we would establish a process of how to access the HRSN services under the waiver for both the youth and the adults.
Okay, this one might be more for you, Commissioner, but how does this interact with our other current reentry programs? Is this basically wholly added or something where we're going to be able to reduce payments and services that will be duplicative now if we already have several reentry programs?
So we, as Alexis said, we have a lot of flow charts going right now to make sure we are not duplicating services. So if there are reentry programs established, we are first trying to determine, are those state funded? And could they potentially be funded through this waiver? And again, under the kind of the premise where we are not seeking federal match because of a Medicaid rule where you can't, we are looking to seek federal match to bring in new federal dollars. The idea being is those new federal dollars, those are the dollars that we would be using to expand or pay for any new services, just the new federal dollars. So if there are reentry services happening today, we are assessing that with all of our state agencies who are at the table. If we're already receiving federal match, we leave it alone. But if we're not, we're exploring as to whether we can bring it under the waiver.
So to expand on that, if you find an agency that's doing reentry that you're not getting a match at and you're not paying for it, you're looking to then bring them into this and now pay for it.
Potentially.
Okay, the matching amount, the 90% that you mentioned, is that guaranteed for the entirety of the waiver? I know there's several times we get a matching amount and then it is decreased in further years. So I just want to make sure we're not looking at an inflated number for 1 year that then drops to 50% the next year.
No, that it should not drop to 50. It's really based on the very, very high percent of adults who are being released that are eligible for our Husky D expansion population, and they are matched at 90%.
And of that, do you know how many of the 10,200 that are 85%? I'm doing algebra now.
Yeah. We
I'm
think
good at algebra.
we think we've heard anywhere from 85 to 90% are Husky D eligible.
Okay. I only have 2 more, Kathy. In addition to I just want to try to wrap my head around making sure I understand this. The current programs that we have, are we currently getting federal match for that 30 days? Because this is an expansion waiver, right? So that assumes that we already have a waiver that we're getting federal matches on.
Yeah, I'm sorry. Right now, for services provided in correctional facilities, we are not getting any match.
So
We're,
it's-
excuse me,
So it's not really an expansion waiver then, because there is no waiver. This
there's
is a
no
new
waiver. This is the waiver to request to seek reimbursement 90 days prior to release.
But this isn't, excuse me, I just want to interrupt. This is an amendment to the substance use disorder demonstration waiver, so that we have a substance use disorder waiver, and this is an extension of that into the criminal justice and the incarcerated realm.
Precisely.
Thank you.
Okay, so it's an extension of a waiver that's
It's an amendment.
not currently in the prison system.
Correct.
This is going to bring it into the prison system.
Come on, Bill, she's going to sit down now.
Okay. Yes. So Representative, well, I'm sorry for the confusion in using the term expansion. We are using a current 1115 waiver vehicle that we have, and that's the substance use disorder waiver, to be able to expand the services that we're offering under that waiver to include this justice involved waiver. So that's what we're doing.
So will this then expand the substance use to have all of these HRSNs
No.
also?
No, it will not.
So it's still going to be kind of siloed. You have the original substance use that is being utilized there. We're expanding that to go into the incarcerated population and providing more benefits there.
It
The
is.
expansion of benefits.
It's more administrative, actually, rather than more substantive in terms of the services. Because we already have the substance use disorder waiver, this is really the most expedient administrative track in order for us to expand that particular waiver. If we were to try to file an entirely new waiver altogether, that's a much, much longer process. So again, this is from the direction from CMS. So administratively, what they've told states is if you're going to file this waiver, use a vehicle that you already have and use that as an expansion of that particular vehicle. And that's the direction that we've taken here.
Okay, that makes more sense. I just
Okay.
hate to see them commingled and then all of a sudden,
No.
you're offering these services across the board
Understood.
for all different things.
Yeah.
The last thing that I had is in relation to the recidivism rates that we're talking about.
Yes.
You mentioned specifically California, with Washington and Montana being fairly new,
Right.
and California really only being about a year.
Yes.
So we really don't know how this is going to affect recidivism rates, do we? Is there any studies out there that show that this specific program with this unknown dollar amount providing all these services is going to affect recidivism?
I don't know if there are studies. I can certainly look and see if there are any, but in terms of any specific data from the states that have only had the program in place for a year, I'm not aware of any at the moment, no.
Okay, thank you very much.
Thank you.
All right, I would remind everybody that we are more than 2 hours into this. And so asking other questions, we still have not gotten to the public. And I think that, we've done this. So Representative Johnson, do you have a question? If you are making a statement, please don't.
I will not. Thank you, Madam Chair. And my question is, does homelessness impact recidivism? So if people are discharged from the prison system into the street, does that create a situation for recidivism, to the best of your knowledge?
To the best of our knowledge, it does.
Thank you so much. Thank you, Madam Chair.
Thank you. And I have a question on the IDDD part of the waiver. I just want to be crystal clear. Does the IDDD waiver, that the IDDD portion of this have to comply with how we handle intellectual and developmental disabilities now, which is an IQ rated system, which is not what other states are doing?
So the way that we've written the waiver, we have a lot of flexibility as to how we can determine whether or not a person meets the standard. So no, it does not have to comply. We can use the standard that we have, but we do have flexibility to use other criteria as well.
Because both Representative Walker and I have been talking about this issue, and because some people have intellectual and developmental disabilities that are incarcerated, but miss the mark because they might be at 71.
Yes.
And that is,
Very
on an IQ standard. So I just want to see if we have that flexibility there, because we are trying to address that issue. And then my last question would be on the mental health medications. So Representative Nolan talked a little bit about medications and for high blood pressure and other things. But one of the things that has happened as someone who worked in the correctional system for 21 years, that would happen is that people couldn't get some of the psychotropic drugs because they're not the same as blood pressure. They're controlled substances, and because someone did not have a place to live, they would not give them their medications. And if you have no place to live and you have no transportation to get someplace to get your medication, again, it's really difficult. Are we making sure that the psychotropic drugs for those, for example, a chronic schizophrenic doesn't become non-compliant with their medication?
Yes. We are doing the best that we can. That is a very complicated issue. And it's one that actually has been raised many times in the process of drafting the waiver and also thinking about what implementation would look like. We think that we will need more support from our DEMIS partners in order to be able to craft a plan that would work effectively for the population that you just identified. It's also a population that our DOC partners tell us it's a very challenging population within a carceral setting, and it will be so outside of a carceral setting. All I can tell you today, Senator, is that we've identified it, we recognize it, and we're going to do the very best that we can to make sure that the person has the resources that they need while they're transitioning, to make sure that they're not decompensating once they are released from incarceration.
And my understanding is there's new medications that are effective for a full year.
That's right.
So
That's my understanding as well.
Representative Nolan.
Thank you, Madam Chair. And what I kind of worry about is some of the disparities that we already see in regards to people incarcerated and coming out into the community. Is there a projected plan that we have that we're going to be able to tell by the, I guess, the data that we're going to be collecting? Is there something that we're planning to do with correcting some of those things?
I'm sorry, Representative, I'm not sure I followed your question. I apologize.
Within the population that we're talking about dealing with, there's most likely going to be a bigger notice of disparities.
I see.
So is there like a plan that we might have that is going to help us correct those disparities that you see in the future?
Yes. So
Can you hear me, Senator?
Okay.
So I'm asking about, you know, the disparities that are probably going to come out of this.
Yes.
And I'm wondering if there is a plan or something that we're thinking about in order to correct some of those disparities that are either ongoing or that we might see because of the waiver.
So implementation, thank you for your question. Implementation is an iterative process. So yes, there's an initial plan to actually look at the data and determine where disparities might be. It might be gender-based, it might be with respect to geography, and any number of factors that you might consider. So that would be the first step in terms of just looking at the data and then parsing it out. And then where we can provide some more support or understand what is driving those disparities, then we will do the best that we can. That's really all that we have right now in terms of an implementation plan. All I can say right now, Representative, is that it is very much on our radar that there are differences in the way that services are delivered to different populations, and our implementation plan will be sensitive to that.
Okay. Well, thank you very much for coming before us. I just feel this weight on my back, so I'm going to just stop asking questions.
I see no more questions for you, Commissioner. And I appreciate all that you have here today. Thank you. We do have the public coming up next. So up next is Curtis Anderson. Is Curtis Anderson here? Okay, Curtis, you have 3 minutes, sir. We won't keep you here for 2 hours, we promise.
Yeah, we already did that, so.
Hello, everyone. I'm here to testify in support of this reentry initiative. I strongly urge that people with lived experience be included in both the design and implementation of this initiative. I was discharged from Connecticut DOC 16 years ago into homelessness. Since then, I've been on a journey to stabilize my life. Even after earning an associate's degree in addiction counseling, I struggle with employment. This initiative will create immediate stability for a person's reentry. 16 years later, Connecticut DOC still discharges people into homelessness every day. This initiative will change that reality. When I say that reality leads to the high recidivism rate in our state of almost 79% of people incarcerated 5 years after incarceration. People with lived experience can be a bridge to help ensure effective implementation so that people can have a measure of stability in their reentry. This program can open a lot of opportunities for people to begin to thrive and succeed in their reentry. Again, I am not an expert on the cost-benefit analysis, yet I know the price we all pay for not offering reentry opportunities of housing and employment. That cost cannot be measured. Public safety is best served when people are housed, offered hope and opportunity instead of being discharged into despair. You know, the period before you get out of incarceration is probably the most strenuous. I know it was for me. You know, thinking about where I was going to go, who I was going to live with, who was going to accept me, you know, how I was going to get on. So that 90 days of someone coming in and talking to a person helps to stabilize them. Because just like we know that in addiction, fear of withdrawal is a driver of behavior, trust me, recidivism and going back, what am I going to do different this time? You know, I couldn't even answer my own mother that. When she asked me what is going to be different, all I could tell her is what I was not going to do. So I just want to put on the table that, you know, I know there's a lot of work ahead. I would be willing to help out whatever way I can. And I know it's maybe not a simple solution. I've heard many things said here today, but again, I think this is something we can all work together on because we all can benefit. Again, when people are housed and employees in our state, public safety is best served for everyone. Thank you for your time.
Mr. Anderson, if you could say on the record your name, because you talked about your experience, but I don't think we heard you say your name.
Okay, no problem. My name is Anderson Curtis. I'm the Senior Policy Organizer at the American Civil Liberties Union of Connecticut, and I am the son of Albert and Rita Curtis.
Very good. Thank you very much. Are there any questions for Mr. Curtis? Representative Porter.
Thank you for being here today and putting a face to the value of what we have before us. You just really reminded me of how important this really is and how real it is. Because I was called one day when someone was released and was told to meet them at New Haven Green. And when the DOC van pulled up and dropped him off, he got out of that van. He was an amputee on crutches. He had a huge box and a huge green trash bag. Where was he going? He was also on dialysis. It was a Friday. He had received dialysis that day, but he had no idea where he was going to get dialysis on Monday. It was a Monday, Wednesday, Friday event. So Yale Transition Clinic was the ones that reached out. Ended up dropping him off at the ER. Who's paying for that? We are. So it's really important that we have people like you that are willing to come before us and share in total transparency and vulnerability what it is they face when they're released and how real this is. So I just wanted to thank you for being here today and shining a light on this. Thank you, Madam Chair.
Thank you.
Thank you, Representative Nolan.
I also would like to thank you for coming here today. Your lived experience is what we're really trying to grasp at and trying to get everyone involved to understand how important it is. Could you just share, if you can, how this waiver would have been important and would have helped you a little bit more if you were able to get the waiver when you were in transition?
Sure. Let's just go to the day of my release. I got out of the van. I took a court trip from Rogowski Prison back to Whaley Avenue Correctional, got out on the side on Hudson Street with nothing. I walked to my ex-wife's house where, you know, because of our previous history, I lasted 2 weeks. I went to Gateway Community College with all of my belongings, ready to go to the shelter that night. because I wasn't going back. No matter what, I wasn't going back. You know, by the grace of God, my mother's older sister came and picked me up from Gateway, and I came to live with her. And that was provided a period of stability. You know, and all before that, before August 17th, I struggled like the whole month. Like, what was I going to do? That question my mother asked me, what's going to be different? I couldn't answer her, you know? And so, you know, it was, all I'm saying is it provides a measure of, it calms people down, knowing that there's not only some help out there, but there's a place to go, right? Which again, is going to make an impact on how you come into your reentry, right? If we want people to just be successful, you know, we can't just say, go out there and just make it happen. You know, people don't become successful by magic. They become successful with opportunities and support. And I believe that this will, again, bring a measure of support to people, that they know there's something out there for them to go to where they can thrive and succeed. And I believe this program will change many lives, because many people could be successful if they have the opportunity. You know, it took me, even with the associate's degree, I couldn't even pay $800 to finalize my education, to get my degree. I did the requirements in 2009. It took me to 2015 to pay $800 because of sporadic employment. And so, you know, there's a reality out there for all of us. And I just want to give you a glimpse of what the reality of reentry looks like for some people coming out of incarceration.
I want to just commend you and thank you for coming before us. And I also want to commend you for saying your parents' names. Some people don't understand saying their names is important to us. And I just commend you on that. Thank you very much, Madam Chair.
Thank you. Any other questions for Mr. Curtis? Seeing none. Thank you very much, sir. You're all set. I'm going to close the public hearing for the joint public hearing for the amendment to the substance use disorder demonstration waiver, justice involved population reentry initiative. It is now closed. And Madam Administrator, let me know when you're ready to, we'll start with Human Services. Is that going to be you, Jillian, or Senator Lesser? Senator Lesser?
Yes, good morning still, Madam Chair. I'd like to call to order the first of the joint meeting of the Human Services Committee for March 19th, 2024. And at this time, I'd like to entertain a motion to approve. I'd like to entertain a motion to approve submission of the waiver pursuant to Connecticut General Statute 17B-8 for the Justice Involved Reentry Amendment, the Substance Abuse Disorder Demonstration Waiver pursuant to Section 1115 of the Social Security Act. Is there a motion by Senator Gaston, second by Representative Gilchrist? Is there discussion? Seeing none, the clerk will please call the roll.
Senator Lesser,
Senator Lesser, yes.
Representative Gilchrist,
Representative Gilchrist votes yes.
Senator Seminara,
No.
Representative Case,
Representative Case votes no.
Senator Gaston, we'll come back. Representative Dathan, Senator Marr,
Senator Marr votes yes.
Representative Butler, we'll come back. Representative Comey, Representative
Comey, excuse me, Representative Comey votes yes.
Thank you.
Just went through why this bill will actually hurt.
Representative Cook, Representative Fortier,
Yes.
Representative Heffernan,
Representative Heffernan votes yes.
Representative Hughes,
Representative Hughes votes yes.
Representative Johnson, Representative Kitt,
Representative Kitt votes yes.
Representative Leeper,
Representative Leeper votes yes.
Representative Santiago,
Santiago votes yes.
Representative Buckby,
No.
Representative Ferraro,
Representative Ferraro votes no.
Representative Mastro Francesco, Representative Pizzuto,
No.
Representative Paletta. Are there any other members of the Human Services Committee that has not yet voted and would like to cast their vote now? Representative Butler, I see you're on.
Madam Clerk, at this point, I'd like to recess the meeting of the Human Services Committee. Nope. No, I'm not allowed to do that. Madam Clerk, will you please announce the tally?
No, you have
Senator Gaston?
Wait. Okay, thank you.
Senator Gaston votes yes.
Thank you.
Madam Clerk, will you now announce the tally?
Total number of voting 19, those voting yea 14, those voting nay 5, 0 abstaining, and 3 absent not voting. Thank you.
And I would now like to recess the Human Services Committee.
Thank you, Senator Lesser. So I'll call the Appropriations Committee meeting to order for an amendment to the Substance Use Disorder Demonstration Waiver Justice Involved Population Reentry Initiative. Is there a motion?
Second.
Moved by Representative Porter, seconded by Representative Paris. Is there any discussion? Seeing no discussion, Madam Administrator, if you could call the roll, please.
Senator Austin,
Senator Austin votes in the affirmative.
Representative Walker, Senator Hartley, Representative Exum, Representative Paris,
Harris votes yes.
Senator Berthel.
This comes
Morning,
down
Madam
to
Secretary.
if on Thursday.
Senator Barthel votes no.
you're out.
I'm sorry, sir. Senator, thank you. One more time for me.
Good morning or good afternoon, Madam Administrator. Senator Berthel votes no.
Thank you, sir. Representative Nuccio,
No.
Senator Anwar,
Senator Anwar votes yes.
Representative Baker,
Representative Baker votes yes.
Representative Belinsky,
Rep. Belinsky votes no.
Representative Callahan, Representative Candelaria,
Representative Candelaria votes yes.
Representative Chaleski,
Representative Chaleski votes no.
Representative Curry,
Representative Curry votes yes.
Representative Dathan, Representative DiCaprio,
DiCaprio votes no.
Representative Delaney,
Representative Delaney in the affirmative.
Representative Delnicki, Representative Dillon,
Representative Dillon votes yes.
Representative Felipe,
Representative Felipe votes yes.
Senator Flexer,
Senator Flexer votes yes.
Representative Fonsello,
No.
Representative Garabay,
Garabay votes yes.
Representative Gibson, Representative Gilchrist,
Representative Gilchrist votes yes.
Senator Gordon,
Senator Gordon votes no.
Representative Gonzalez,
Representative Gonzalez votes yes.
Representative Haddad,
Representative Haddad votes yes.
Representative Hall. Representative Harrison,
No.
Representative Hoxa. Representative Hoxa? He's on. You're muted.
Sorry about that. Rep. Hoxa votes no.
Representative Johnson,
Representative Johnson votes yes.
Representative Khanna,
Representative Khanna votes yes.
Representative Kennedy. Senator Lesser,
Senator Lesser, yes.
Senator Marks,
Yes.
Representative McCarty,
She should be walking into the room any moment.
thank you for the update. Senator McCrory. Representative Nolan,
Representative Nolan in the affirmative.
Representative Porter,
Representative Porter votes a resounding yes.
Senator Kushner, did I skip you?
You did. I was gonna wait till the end.
Sorry, Senator Kushner.
Senator Kushner votes yes.
Thank you, ma'am. Was so excited. to get-
Oh, there he is.
Oh, there he is. Senator McCrory.
Senator McCory's right here. Senator McCory, you want my vote?
Voting?
Would you like my vote?
I would love your vote, please.
My vote is a yes for Susan.
Thank you, sir.
Yes. Any more votes you need from me?
No, sir. Goodbye.
I'm done for the day.
Goodbye.
Goodbye.
Representative Osborne.
Osborne, yes.
Representative Reyes.
Representative Reyes in the affirmative.
Representative Rosario.
Representative Rosario votes yes.
Representative Retigliano. Yes. Representative Ryan.
Representative Ryan votes yes.
Representative Sanchez.
Representative Sanchez votes yes.
Senator Slapp.
Senator Slapp votes yes.
Representative Sims. Senator Summers.
Summers votes no.
Representative Tersiak. Senator Winfield.
Senator Winfield in the affirmative.
Representative Zawistowski.
Representative Zawistowski votes no.
Are there any members of the Appropriations Committee who have not yet cast their vote?
Representative Exum votes yes.
Thank you, ma'am.
Thank you.
Senator Hartley. Thank you. Anyone else? Madam Administrator. Oh, I was gonna come back to it. Representative McCarty.
Yes, Representative McCarty votes yes.
Thank you, ma'am. Anyone else? Madam Administrator, for the record, Representative Walker gave me permission to say why she's not here today. She had a family funeral and could not make it, but if she had been here, she would have been a resounding yes.
That doesn't count.
I know, but it has to be said.
He said the
Anyone-
same thing about
Okay, ladies and gentlemen, I'm in the process of taking roll call votes. Thank you.
Madam Clerk.
Representative Paris. Representative Kennedy.
Thank you, Madam Clerk. Madam, Kennedy votes yes.
Thank you, ma'am. Anyone else?
Yes, please.
Representative Tersiak.
May I?
You certainly may.
Am I getting through? Hi, yes, please. It's Representative Tersiak. May I vote?
Please, how would you like to cast your vote, sir?
Hi, Representative Tersiak votes yes. Thank you.
Thank you, sir. Anyone else? Madam Administrator, do you have the tally?
Yes, ma'am, I do. Total number voting 48, those voting yea 36, those voting nay 12, those abstaining 0, those absent not voting 5.
The motion passes. I would entertain a motion from Appropriations Committee members to adjourn this portion of the meeting. Representative Nolan, is there a second?
Second by Parrish.
Second by Representative Paris. All those in favor indicate by saying aye.
Aye.
Any opposed, any abstentions? We are now adjourned.
Madam, I'd like to reconvene the Human Services Committee. And at this time, I would like to entertain a motion to adjourn. Is there a motion? Representative.
Somebody needs to give her a motion.
Representative Fourier's, motion by Representative Fourier, second, all in favor?
Aye.
We're adjourned.